So after all those extensive and wonderful innovative sessions, we're going to be wrapping up with the fourth session right now. And following the fourth session, the winners will be selected and we'll be having the final session. So I'm very happy to welcome all the judges, Dr. Haldi Purkar sir, Dr. Naresh Babu, Dr. Parikshit Gokate, Dr. Santosh Bede, Dr. Naren Shetty, Dr. Mahesh, Dr. Rishi Swarup, Dr. Ilan Kumaran, Dr. Ramakrishnan, Dr. Arshad, Dr. Ramesh, and Dr. Rajalingam. So we're going to be having 10 speakers. So I'd like to call upon the first speaker, Dr. Kunal Mandli. So he's going to be talking on paper-assisted scleral simulator, novel device for dry lab surgical training in COVID-19 era.
Paper-assisted scleral simulator. The authors have no financial interest. India, a land of culture, diversity, heritage, and the second largest contributor of the world's total population. With substantial increase in populace above 50 years of age, the load of cataract blind people would increase up to 8.25 million in the year 2020. And the quantum of cataract surgery would also be doubled to 7.3 million in the same year. With the vision of eliminating needless blindness, approximately 44% of Tamil Nadu's total cataract load is being operated by the Arvind Eye Care system alone. Owing to this, n number of ophthalmologists are being trained in cataract surgery by Arvind year by year. This immense responsibility in training and sculpting their newly fashioned surgical hands lies on the educator, who upskills the basics and teaches a proper conventional method of ocular microsurgery. As the budding hands are going to change the future of eye care, this manual SICs bestow the stepping stone for phacoemulsification all over the world for any ophthalmic surgery. Cataract microsurgery is not just removing the natural lens and placing the IOL inside the eye. It is way more than it. Young residents with full enthusiasm when enter the operation theatre are usually mesmerized by the act of performing surgery. But the hitch emerges in training the hands of amateur surgeons while starting their surgical walk of life. Tremors of the hand, palpitation, sweating, increased heart rate creates a stumbling block leading to fear, anxiety, and further landing onto complications. But to master the initial triplanar sclerocorneal tunnel on which the whole surgery is dependent is challenging, as if the tunnel incision goes too deep, the iris keeps on prolapsing, making it difficult for further steps. And if the tunnel incision becomes superficial, it results in buttonholing. So any direct attempt may jeopardize the patient's eye. So to reduce this, we already have a well-equipped wet lab, where young surgeons can practice and program their hands accordingly. Learning and performing on goat's eye or a human eye is not always possible. Moreover, there is also a limiting factor for those used inside the operation theatre. Considering it, we analyzed various materials which can replicate the surface of the sclera to some extent. Hence, we tried and tested easily available materials such as papers and cardboards of different thickness. On further exploring, we grabbed an idea of practicing tunnel on a sheet of paper which had a peculiar thickness of 0.25 mm. Those were our regular sheets which were used daily in our hospital. A detailed study was required about this paper, so we asked our residents to practice on it by making an incision with 15 number blade and fashioning the scleral tunnel by crescent keratome, further wriggling inside without perforating the paper as we do while making the tunnel. As this method became popular among novice surgeons, we decided to increase the magnitude and to give them a feel of making a scleral tunnel in perfect human eye. On further researching, we came across a tracer sheet. The importance of this tracer sheet lies in the fact that if a paper is designed in an exact pattern, the resultant flower-shaped structure gives an approximate curvature of an eyeball without any breach on joining the edges of the paper. With the help of the tracer, we were able to get our target structural base required for the tunnel practice. But the main problem we still faced that we lacked a holder which can clutch the paper over the eyeball. Sticking the paper with a gum would knock down the purpose of making it reusable. So we thought of making it by a 3D printing technology. 3D printing process builds a three-dimensional object of complex shapes and geometries designed by a computer by successfully adding materials layer by layer, which is solidified under computer-guided software. By this, we designed a holder-cum-stand model in CAD software and calibrated it in correspondence to sclerocorneal junction. After 3D printing it, we fixed our pre-cut tracer marked sheet of paper over it to practice. This is how our paper-assisted scleral simulator, also known as PAS, came to existence. To our expectations, the results were far appreciable and promising. Now residents were able to practice as many times even in the OPD and their home, as it didn't require the wet lab and the microscope. They could even practice inside the OT, which provided them more finer and softer hand movements required for a good microsurgery. So we have finally innovated a low-cost effective technique for the tunnel practice by locally available materials. PAS can be used for practicing different surgical steps like scleral tunnel, trabeculectomy, scleral flap, scleral tear suturing, etc. and can also be used inside the OT. Thus, the most important initial step of cataract surgery, which usually increases the heart rate of young surgeons, will now be much easier to master. Now forget your past by using PAS and have a great surgeries ahead.
Thank you, Dr. Kunal. Before going ahead with the opinions of the judges, I would like to welcome Dr. Vinod Mehta, Dr. Vavikar sir, and Dr. Parikshit sir. Sir, opinions of the judges regarding the talk.
Actually, in cricket, the by-runner also will be wearing the helmet, guard, everything. The reason I am saying is, like when you are doing a simulation, the person should be wearing the gloves, drape, everything, so that at least the gloves, so that they'll get the feel. So you are doing it with bare hand when you're doing the simulator. And if you're going to wear the gloves and do it on the human eye or whatever it may be, it changes actually. So when, in case if you're training, I think they should at least wear the gloves. And in fact, if it is microscope, it is even better, because bare eye is different and doing under the microscope is different.
Yeah, that was the main point, sir. Every time access to the wet lab is not available. That's why we had to make an structure which can stabilize the paper. That paper was mainly 250 GSM thickness. That gave similar feel like sclera, and if we have tried with many different GSM thickness papers, so that mainly if we tried using thinner paper, that used to perforate very easily. So and if we tried too thick like cardboards and all, that didn't increase the confidence of the students. So that's why we use this 250 GSM paper that gave almost the feel like sclera. And
no, it's not about the feel of the sclera.
Yeah.
I'm not talking about the paper actually. It's simulating the real life situation, I'm saying.
Yeah. Oh. So this next one is also my presentation. So in this we have tried to create a low cost burr. Normally a burr which is used in pterygium surgeries to remove the residual pterygium tissues.
Can you start the presentation, sir?
Yeah, I'll just start.
Yeah.
I'll just speak up. So normally a burr which is used in the pterygium surgeries to remove the residual pterygium tissues, that is very costly. So we have tried to create it in a low cost manner.
A pterygium is a wing-like growth of degenerative subconjunctival fibrovascular tissue that crosses the limbus and encroaches the cornea, causing ocular irritation, inflammation, and poor cosmesis. Recent times have seen an upsurge in the number of pterygium excisions being performed. With the use of conjunctival autograft and fibrin glue, the recurrence rates have massively dropped. However, remnant pterygium tissue on the cornea can contribute to poor symptomatic relief and dissatisfied patients, not to mention the unacceptable cosmesis. In advanced and strongly adherent pterygium, dissecting it off the cornea can prove to be quite a task, and one may end up with inadequate dissection and remnant tissue over the cornea, resulting in poor cosmetic outcomes and uneven ocular surface, thereby rendering the whole procedure futile. An effective solution for this is the diamond burr, which aids in the removal of densely adherent pterygium tissue and smoothens any surface irregularity. It is an indispensable tool, and inevitably it comes with a price. A commercially available burr can cost anywhere between 68 to 75,000 rupees. We at our institute have designed a much cheaper but equally effective alternative to the commercially available diamond burr. The raw materials required to build this are a 50cc syringe, a switch, a motor, a 9-watt battery, and a burr tip that is used in most commercially available burrs. The 50cc syringe is dismantled and the plunger is separated from the barrel. A window for the on-off switch is cut out in the syringe barrel, and the needle adapter is also cut off. A motor to power the burr is inserted first into the syringe, followed by the 9-watt battery. The switch is now lodged into its opening in the syringe tube, where it fits snugly. This arrangement is held in place by closing the tube with a plunger seal. Finally, the burr tip is attached to the motor by placing it in the position of the needle adapter. The burr is now ready to be used and is turned on and off using the power switch. A steady flow of balanced salt solution is injected while the burr is used on the cornea to dissipate the heat produced. The rotating action of the burr tip loosens the densely adherent tissue of the cornea, thereby facilitating its easy removal and smoothens any surface irregularity caused by the thick pterygium tissue. The post-operative outcome is a smooth, even corneal surface without any residual pterygium tissue. This ensures complete symptomatic relief as well as a desirable cosmetic outcome for the patient post-operatively. The cost of this alternative is under 3,000 Indian rupees, a fraction of the cost of the conventional burr.
Thank you, Dr. Kunal. Thoughts, Dr. Naresh Babu, sir?
How do you sterilize this?
So normally we used ETO also. We have tried. We normally in our OTs we have used ETO, and we put in ETO bags and then ETO it right regular instruments.
And what is the RPM of the meter, motor which is used? Because can it be standardized?
We are designing another design also where we are using a regulator to control the RPM. That is still under development. So this design, it's directly the switch, which gives the power, and the motor rotates at the maximum RPM.
Yeah.
So
you cannot control it.
No,
basically.
it's not. And the other design which we are designing right now, we are trying to fix a rotator like a regulator of the fan like that to regulate the RPMs.
Is there any chance of the burr coming out of the motor?
No, we are using it regularly. It's not.
How it is fixed?
Snugly. No, the burr tips are the same like what we get commercially. Those cost like 1,500 like that. The main cost comes from the main motor. So that only we replaced it.
No. What I'm asking is dislodging of the burr from here.
No, it's not. It
because
fits.
this is designed for the other motor.
No. The hole inside the burr tips snugly fits in the motor head.
Oh.
And what would the lifetime of this be, sir?
Sorry?
What would the lifetime of this be? How many cases can you use this for?
We are using it regularly since 1 year, 1.5 years. It doesn't give any issues.
And do you charge the patients extra, sir, for this?
No.
Nothing. Okay.
Nothing.
Okay. Thank you.
Thank you.
So the next talk will be by Dr. Shivraj. He'll be talking on the incremental innovations in eye care. And I would request Dr. Vignesh to be ready with the next talk. I would request Dr. Kunal to collect his certificates, please. Dr. Naresh Babu.
This is big. You have opened Vignesh, Dr. Vignesh's. No, I am Dr. Shivraj. You have opened Dr. Vignesh's PowerPoint. Yeah, this is me. Okay. Good afternoon, everyone. So I'm Dr. Shivraj Tagare, and I'll be talking on my topic, incremental innovations in operation theatre in form of a video. So these are innovations that we tried on many various simple problem statements that we face in everyday OT in Arvind Hospital. And these are like simple solutions to various problem statement I think can be effective for the long term. So I'll starting my video.
Anterior stromal puncture for toric IOL. Errors can occur while marking associated with smudging or fading away of dye during pre-operative reference axis marking. Anterior stromal puncture creates a point mark without any epithelial erosion, and the simultaneous staining helps in perfect and long-time retention of the dye. Thus, ASP stain stays for more than 48 hours. Low-cost, high-definition Raspberry Cam. Raspberry Pi camera is a fully functional Linux-based computer that can be fitted with a HD camera module. An adapter, which is portable and also small enough to mount the Raspberry Pi, can be fitted to the observer eyepiece. It has a better quality than the more expensive commercially available systems like conventional camera, and mobile phones is more portable and records videos in high resolution. 5-cent airway for patients to breathe easily during surgery. The lanyard that is thrown away after each conference can be reused in this manner. The one end of the lanyard is tied to the microscope and the other end is clipped onto the drape during surgery. It also has a sliding note to adjust the drape height. COVID-19 safe intubation hood. A simple structure made from PVC pipes and plastic sheets. This intubation hood will minimize the spread of microdroplets and aerosol while intubating and extubating the patient. OT trolley sanitizer dispenser. It is portable and foot pedal controlled. It helps in hand sanitization by the OT personnel at frequent intervals. Spring action apparatus for fixation of eyeball is a robust, simple and economical device to solve the problem of achieving a formed and firm eyeball which is stably fixed in a holding device in surgical wet lab training. The spring action syringe generates vacuum and enables reliable fixation of human and animal cadaveric eye on the iron cylinder. The rise in intraocular pressure due to vacuum fixation can be varied as per need or nature of surgery. Magnifier screen. Magnifier screen is a simple tool that can be used to read fine prints of automated printouts and match IOL labels before cataract surgery without using presbyopic glasses, microscope simulator or simulator box. To avoid the confusion for patients to focus on the light during phaco and flax and help them focus, we have devised two simulators mimicking the light source of operating microscope and flax laser, which are shown before surgery to help the patients to know what they see and what they must focus.
Thank you, Dr. Shivraj, for those wonderful collection of small innovations. Dr. Rishi Swaroop, sir, your thoughts?
So very interesting little innovations, and I think an institution like Arvind, where you're doing a large number of surgeries, these can certainly come in very useful. So must compliment whoever's put their thought to making this.
Yes.
I think especially the one to hold the drapes up.
Yes, sir.
We all can take our tags back and
Yes,
use
sir.
it. We use something similar in our hospital. We use a hanger,
Yes, sir.
which we close the hanger, we just bend it and put it in front of the patient's mouth, and that also works quite well.
Yes, sir.
So congratulations.
Thank you, sir.
Good ideas.
Thank you, sir.
So next I would like to call upon Dr. Vignesh to talk on synthesis of a novel compound for use as a sealant in posterior capsular rents. Dr. Shivraj, please collect your certificates.
Good afternoon all. So today I'm here to discuss about innovation, the synthesis of a novel compound for use as a sealant in posterior capsular rents. So as we all know, incidence of posterior capsular rents is from 0.45% to 3.6% for experienced surgeons, and among residents it's a bit more, and approximately 10 million cataract surgeries are being performed here every year worldwide. Roughly this translates to around 4 to 5 lakh posterior capsular rents every year worldwide. So expert surgeons usually PCR is recognized quite early and appropriate measures are taken, whereas for trainees or residents, PCR and its subsequent potential complications such as aphakia can be a nightmare. So what we attempted to do is to achieve a workaround negating PCR as a complication of cataract surgery. So we wanted to develop a compound which can spread as a film and act as a glue to bridge the margins of a PCR or even an ALC tear. And we wanted to test the compound in animal eyes as well as in lab setup to see if it can achieve set objectives. So the compound that we chose to use is polyethylene glycol based hydrogel compound. PEG is known to be inert and transparent, and it is also biodegradable, and also it has already been used as part of drugs which are injected, and as well as in adhesives which are being used in ocular purposes. So, and for synthesis, we used multiple trials were done with different PEG-based hydrogel compounds, and one compound which showed promising results was lyophilized and tested in vials and in animal eyes. So this is just a graphical representation of what we intended to do. So here is the anterior lens capsule tear on which we intended to place a blob of the gel which would hopefully hold it together and prevent it from spreading further. And similarly, in a case of posterior capsular rent, we wanted to place a blob of the glue across the rent and hope that it holds repairs the integrity of the capsular bag and supports an IOL. So in the animal eye experiment, we totally excised the cornea to improve visualization, and the capsular access was done in the usual method after trypan blue solution. Lens material was aspirated, and a tear was induced both in the ALC and posterior lens capsule. The gel was reconstituted and spread over the ALC and the posterior capsular end. So here we can see the region of the ALC tear and the region of the posterior capsular end both in the same eye. The ALC flaps were kept in apposition before the gel was applied. So here we were able to see the gel applied over the ALC and as well as the PCR tear. So the observation of our experiment was that the gel, although it formed a kind of a blob, it was unable to adhere properly to the biological membrane, and even after 10 minutes it was washed away by irrigation. Whereas in a lab setup, the gel formation was noted to occur within 1 minute and the gel adhered to the walls of the vial. So in this picture, we were able to see that even on inverting the vial, the gel was found to maintain integrity and held on to the vial, and it stuck onto the top of the vial and did not dissolve. And it was noted that the gel retained its properties at room temperature for 60 days. So the results as well as limitations is that it works well in vitro with desirable properties, whereas in the animal eyes, it does not work properly. So future directions, altering the concentration of various constituents used for gel formation will allow gel adherence in vivo. And this compound is protected by provisional patent applied to JIPMER. Thank you.
Thank you, Dr. Vignesh. Dr. Parikshit, sir.
Sorry, sir?
Have you done a proper prospective study for this on some cases, or it's just innovation?
No, sir, it is just in the lab and on the animal eyes, which we have obtained from an abattoir, sir. It is not, we have not yet
done.
Yes, no, sir.
Yeah.
But we intend to do it once it works.
You will have to do it. But then the follow-up is also for a few hours in animal eyes,
yes,
not
sir.
more than a few hours.
Sorry, sir, in follow-up in the sense?
Once you put that gel,
yes,
and
sir,
you formed a membrane,
yes,
on which the lens was put.
Yes, sir.
So you followed it up for how long?
No, sir, like, so we waited for 10 minutes and we hoped that it would hold on to the remnant of the PCR or the ALC. And we tried irrigating it. The moment irrigation was done, it got washed away. So we are intending to go back to the lab and try out similar compositions so that it holds on to the membrane. So that is what we are trying to achieve.
If it is done in a cataract surgery, there will be irrigation all the time.
Yes,
later.
sir. Yes, sir. So that is the limitation.
Can I just give a small
question.
suggestion? Maybe you instead of trying to make the gel on the spot, you can make like a membrane from the same composite.
So
and you can put a whole membrane covering the entire posterior capsule.
Like a film.
And then later it can get absorbed or dissolved in the eye. That may be more feasible.
That is what we are planning in the next stage, sir. Thank you.
Actually, it is an animal model or a cadaver model, because animal model means you should simulate a cataract surgery. You said you are removing the cataract and you are doing So it's not an animal model, it's a cadaver model.
Sir, it is a goat's eyeball.
Yeah, that is a cadaver, boss. It is not an animal model, it is a cadaver model. Both are different actually.
Yes,
so in animal model, you will get a real-time simulation, right?
Okay,
You'll be doing a cataract, you'll be making a PC rent, the vitreous will, here it is a cadaver eye.
Yes,
so both
sir.
are different.
Yes, sir. Okay,
You don't have the dynamics in cadaver eye.
Yes, sir. Thank you, sir. So actually we made a very large rent so that which would preclude lens placement, sir. So that was our intention, but since it is not working out, so we are planning on further trials in the lab, sir. Sorry, sir. Vitreous disturbance. So yes, sir. In that case, then the eventual idea is that we'll have to do vitrectomy and then place the gel so that the lens can be placed in situ. Is the material biologically available or you have synthesized? No, sir. It is synthesized, sir. So one of our co-authors has synthesized it in the lab.
Is it inert?
Yes, sir. It is. It is one of. It's a compound synthesized from polyethylene glycol, sir. So polyethylene glycol is a known inert and transparent substance.
I think you are doing a VR fellowship, right?
Yes, sir.
Then why are you doing all these things, boss?
Sir, actually, I did it during residency and...
Now, what will you do for your food?
Thank you, sir.
So, I would ask Dr. Vignesh to collect his certificate. Next, I would like to call upon Dr. Shreyoshri Ghosh. She'll be talking on revelation. VEP amplitude and latency are unrelated variables. Amplitude is reduced in retinal disease.
Good afternoon, everyone. I'm Dr. Shreyoshri Ghosh, and under the guidance and innovation of Dr. Parthasarathi Roy, I'm here to present that VEP amplitude and latency are unrelated variables and that amplitude is reduced in retinal disease. So there has been a huge discussion regarding retinal and optic nerve disorders and how we investigate them, in which ERG and VEP have been differentiated, where VEP is basically for optic nerve dysfunction and ERG for retina. This belief ignores the basic fact that for a VEP response to be evoked, a retina has to be intact. So to prove that VEP parameters are affected in retinal diseases as well, we have employed a strategy to find out whether the amplitude and latency are related or not, both in healthy eyes and in retinal disease patients. Here we aim to segregate that retina is the seat of electricity generation, which is being represented by amplitude, and optic nerve is the vehicle for electricity conduction, represented by latency. So here we have compared our optic nerve pathway to the generation of current in an electric bulb, where electric action potential is being generated in the retina as generator and conduction is through the optic nerve. So this is an institutional-based cross-sectional observational study done in AIOS, Kolkata for 1 year, 6 months, where we have taken a population of 130 normal volunteers with BCVA 6/6, and we have performed pattern reversal VEP on Retimax machine. 2 variables have been taken, N75 P100 amplitude and P100 latency. Another group is a sample of retinal disease patients which had been referred from the OPD to our lab, and a parameter of 16 eyes of 9 patients suffering from various retinal diseases were included. The results that we got in the normative data group, we see that the R, that's the Pearson's coefficient of linear correlation, is 0.1 for right eye and 0.02 for left eye, which shows that there is no relation between the latency and amplitude. And a similar finding was found also in the retinal disease patients, both for right eye and left eye. We have also seen that there is severe reduction of N75 P100 amplitudes of both eyes, but there's retention of absolute normal latency in the retinal disease patients. Further analysis showed that in normative data group, we can see that the points are clustered along a normal horizontal line, showing that there is again no relation between the X and Y axis, and a similar finding has been found out in the retinal disease as well. So in conclusion, I would say that probably in literature there has been no such study where a relation between these 2 variables has been undertaken. And for retinal disease, a definitive pattern has been, we have tried to evolve a pattern through this study. Maybe this is an expression of the all or none law that still needs to be investigated. And through this, it is helpful for those centers which do not have an ERG machine, and they can only with the presence of the VEP machine they can try and differentiate between a optic nerve disorder and retinal disorder. Thank you.
Thank you, doctor.
130 normal.
So 130 normal, and the retinal group 16 because it was a chance finding from our previous records that we had in the lab.
So I think comparison of 130 versus 16 is a bit
Yes, sir.
skewed. Second thing is what sort of retinal diseases were there? And was
So I've
there any
mentioned it.
differences in the pattern of the disease and your observations?
So in retinal diseases, we have taken mild NPDR, RP atrophy, Stargardt's disease. And so the sample study is much less as compared to the normal one.
But was there any difference between an NPDR patient and the other retinal diseases patient? Findings wise?
So actually, the patients which were referred to us were directly from the OPD. So, so are you asking for the ERG, the VEP findings?
Yes, yes.
Yes, so they were different. I mean, the values were different.
Patient with NPDR and patient with other retinal diseases, was there any difference in the finding?
Yes, there was a difference in the values.
What was
but
the difference?
So the values for the latency and amplitude were different, but a common finding that we got was that though there was a reduction in the amplitude, the latency remained the same, which is what we found. Yes, sir, in retinal diseases.
So what is new in this, basically? What does this imply, or what is new in this your study?
So earlier it has been always said that for retinal diseases we would employ ERG, and for optic nerve we'll employ VEP. So through this study, though our study group is very small, it's just 16, we want to show that that if in retinal disease we get the latency to be much less, even though the amplitude is same. So an electric pathway is taking place, but we know there's V is equal to IR, there's an equation. So it's very unique to say that there's no relation between these two.
No, but
so
you mean that if the patient is having any macular pathology and still the latency will be same as
so
a
that is
normal
what we have
person?
found out, and
It's same. A patient with macular disease, you have done VEP, the latency of that patient, and a normal individual, the latency of that, will that be same or will it be different?
No, sir, not with the normal individual. The normative data group shows a different finding, and the retinal disease group is showing a different finding. Here we are trying to compare between optic nerve disorders and retinal disorders.
You mean to say that even if a retinal disorder is suspected, you can perhaps
Use a VEP for differentiation.
No. But VEP is for optic nerve, and for that your macular function has to be normal, right?
Yes, sir.
Because while doing VEP, we do a pattern stimulation of macula. So if your macula is not good, it will not get stimulated and the latency will not be normal. But you are saying that in your study it was normal.
it just has an incremental value. I mean, if you have a OCT, I mean, a clinic that will have VEP will definitely have an OCT also, which will give more
ERG actually.
But even then, we cannot compare with the ERG. ERG will give a lot of information.
Yes.
Yes, so ERG is always.
That will give all the information about the layers.
So, but.
Hey, congratulations on trying something new. You need to do more study and
Yes,
more
sir.
patients should be examined, and maybe next time you will have a more set of patients. Thank you.
Thank you, sir.
The next speaker will be Dr. Divya. Is Dr. Divya there? Okay. Next will be Dr. Ayman Khan. Yeah, thank you.
Good afternoon, everyone. My talk is based on the blue light imaging of corneal fluorescence strained corneas. I have a video.
Patients in the ICU are at a higher risk of ocular surface disorders due to metabolic derangements, mechanical ventilation, and decreased level of consciousness, and are often unable to convey their ophthalmological complaints. As ICU staff are primarily concerned with stabilization of vital bodily functions, they may lack awareness of the risk of ocular surface disorders and fail to perform regular ocular screenings, which may lead to visual threatening complications. What if we had a do-it-yourself pocket-friendly device that could easily be used to screen and treat such patients? We present to you Smartphone Co-aided Cobalt Blue Photography Do-It-Yourself, or Scooby-Doo, an innovative do-it-yourself tool which can be used to carry out blue light photography of fluorescent stained corneas without the aid of a slit lamp. This device requires simple, easily accessible material such as chart paper, double-sided tape, intraocular lens, acrylic blue filter sheet, hole puncher, a scalpel, and a ruler. To assemble, 1 cm into 8 cm strip of black chart paper is cut and 5 marks at 1 cm apart are placed. Double-sided tape is placed from the 3 cm to 5 cm section of the chart paper. Distance from the center of your phone camera and flat light are measured, and the distance is marked on chart paper between the 4 cm and the 5 cm section. The chart paper is folded over at the red dotted line, and 2 punch holes are made on the marked area as shown in the figures. The cover of the double-sided tape is removed and the IOL of the appropriate power is placed on the 4 cm marked punch hole and the chart paper is folded over. The acrylic piece is placed over the punch hole. Device is aligned over the camera, cell phone and kept in place with microboard. By placing the acrylic blue filter over the smartphone camera flash, blue light in the range of 450 to 490 nanometer passes while the other wavelengths are filtered out. We were able to capture high quality images of multiple conditions such as diffuse punctate epithelial erosions due to dry eye, inferior punctate epithelial erosions due to lid pathology, bulbar conjunctiva staining due to Stevens-Johnson syndrome, large epithelial defect, an epithelial component of graft rejection, dendritic viral keratitis, filamentary keratitis, a total epithelial defect seen in postoperative day 1 of a total penetrating keratoplasty. We were even able to capture a high definition video demonstrating Siegel's positive test in the case of a penetrating trauma. This device was also useful in teleophthalmology for diagnosis, photo documentation, and treatment counseling of patients. For your consideration, your best friend in screening ocular surface disorders in a setup where slit lamp is not available, Scooby-Doo, a do-it-yourself pocket-friendly tool to keep avoidable vision-threatening conditions at bay.
Thank you, Doctor. Dr. Mahesh, sir, your thoughts?
Actually, yeah, what, sorry.
Yes. No, sir. The IOL actually magnifies the image. So previously we had this anterior segment imaging with the IOL. So this is an add-on to that. So with the IOL magnifies the image and we can get a high quality magnified image.
Where will you get this cobalt blue filter from?
So this is actually an acrylic sheet, sir.
Acrylic sheet, that's all.
Yeah, acrylic sheet outlets, if you go, they actually have the specific nanometer which you want. And they itself, they'll cut and give you this thing, sir. You have like, you can just make multiple.
Oh, okay. Then this was published in, this sort of one similar article was published in IGO last year.
Yes.
How different is this from that? That was
Yes.
by Adul Puttalat.
Yes. So this device is, one thing is we have added IOL also to this. Yes, also added IOL. Okay. Yes, also added IOL. Yeah. And then this is more like a do-it-yourself sort of thing, sir. We wanted to make it like
little more simple.
Yeah, do-it-yourself sort of thing. So anyone can make it and start using it.
The same principle.
Yeah. Okay. Yes. Yes, sir. Just have to measure the distance between the cell phone and the flashlight, and then keep the pieces of IOL and the active filter in that distance, and you can use it.
No, the previous.
Yes, sir. Yes, sir. On the IOL only, sir. There are 2 punch holes. So one punch hole will for the IOL.
No, no.
No, sir.
No.
the filter is below and the IOL is above that, sir.
What's the power of the IOL?
We have used a 15 diopter lens, sir. So because we get a greater depth of focus, so it's easier, to focus. Yeah, it's easier to focus. Otherwise, if you do a higher lens, even though we get a higher magnification, it's difficult to focus. The plane is just a very small change, and it will change the clarity of the image.
Thank you, doctor.
Excuse me. What's your experience? Do the ICU guys use this?
Sir,
what's your experience? Do the ICU guys use this?
Sir, I have not actually worked with them yet, sir. But I feel like since it's portable and you can easily use it with your own phone, it's probably you could use it.
There are no further comments. Thank you. Next will be Dr. Tejaswini. Dr. Tejaswini. Dr. Prithvi. Yeah.
As an ophthalmologist, there are situations where you cannot diagnose or treat a case just because you don't have the right instruments in hand. To overcome this challenge, we have brought to you the Smart Scope Kit, a must for every ophthalmologist. A kit which consists of every small tool needed for diagnosis from anterior to posterior segment with the help of a smartphone. For examination of the visual acuity, we have a smartphone-based Snellen chart which can be downloaded from the Play Store or the App Store. We have a trial frame with a occluder and a pinhole, and also a +10 diopter lens. Hence, we can have a preliminary examination of visual acuity of patients with these instruments. Next range of instruments are for investigations. As you see, the most important is the torch. The next is a BP apparatus, a pulse oximeter, a syringe and a cannula to check duct patency, a glucometer, dilating and anesthetic drops, hand sanitizer and wipes, fluorescent strips for corneal pathologies, forceps and sterile 26 gauge needle for foreign body removal. We also have sterile histopad slides and spatula for corneal scraping, sterile gloves for safe examination. Now we move on to the range of anti-segment examination tools. The first is the iVerter for lip diversion and examining superior tarsal conjunctiva. The ASPE or the anterior segment photography using intraocular lens for smartphone based anterior segment examination, Schiot's tonometry for IOP measurement, and ASPE Gonu for examination of angle structures. We also have IOL scope, a IOL based microscope for smartphone based detection of fungi and parasites. Posterior segment examination tool include the Trash to Treasure RedCam for fundus examination using dilating drops. This kit comprises of frugal do-it-yourself tools required for basic examination of patient from anterior to posterior segment. It is smartphone based and helps us in storing images, videos, helps us in teleophthalmology for expert opinion and for resident learning and teaching. It is easily portable, it's a do-it-yourself, cost-effective, universal kit which can be used in peripheral centers, local clinics devoid of expensive equipments. Also, it's ideal for examination of patient in outreach camps.
Thank you, Dr. Prithvi. Dr. Arshad, sir.
Yeah. Dr. Prithvi,
Yes.
I would just like to add, you can also incorporate an Amsler grid chart.
Yes, sir.
That is something which is...
Yeah, actually, the smartphone application which we have...
Maybe, because that is what, otherwise
it's
you
already
can even
there
have
in
a
that.
paper.
Yeah.
So that would be an additional.
Yes.
And otherwise, just like what the oral lab people have. If you plan, we can have it in the form of a kit, which could be marketed, and that would come in handy because it won't cost more than 1,000 rupees.
Yeah, it doesn't.
Yeah. So thank you very much. Thanks.
Any other comments, judges? So I'm sorry, the two more speakers have not turned up. So this would be the session, end of the session. So we'll be coming back for the final.
दो लोग हैं सर वो एक्चुअली दो प्रेजेंटेशन थे शी इज नॉट ना तेजस्वी दैट्स व्हाई
I would like to thank all the judges for being here.